Hello and welcome to this presentation on the Key Features Questions paper from Senior Cycle 1 Family Medicine at RCSI Perdana. My name is Professor Anthony Cummins. We changed the format this year. Up to 2016, we used to have an MCQ as well as a data interpretation paper. And we feel that the Key Features Questions format more accurately and reliably assesses students' abilities to prioritize. In the past, with the data interpretation paper, students were not negatively marked for suggesting additional answers to the correct answers, whereas with this particular approach, the key features questions, marks are deducted for inappropriate responses or for failing to identify the correct choices. And the purpose of this is to facilitate your ability to prioritize, making sure that the choice you make, either in diagnosis or treatment, is the most appropriate or relevant to this patient at this particular time. So it's good training for your future career. Let's look at some examples. Case 1. A 68-year-old male smoker consults you with an acute problem. He's developed back pain for the previous 10 days. It really is to the lateral aspect of his right thigh. It's worsened over that 10-day period. It's not responding to simple analgesia. He's had no fall or no injury, but he does have an associated sensation of pins and needles in his right lower limb. Okay, your first question is to please list 2 relevant questions that you would like to ask, the answers to which could help you to arrive at a differential diagnosis. Now, if you list more than 2 questions, you receive 0 marks, or if you list questions that are deemed irrelevant based on the history you've just seen, you will also receive 0 marks. So the first question you should ask is, have you had a previous lumbosacral disc prolapse? Because if he's had, then the likelihood that this is another is high probability. The other question you should ask is, have you developed unexpected incontinence of urine? Now, this question should be asked in a particular way because this is not to do with having back pain and therefore having difficulty getting to the toilet. This is where somebody has been sitting or resting, and then when they get up from their seat, they notice that there's a wet patch underneath them and they had not been aware of it. It's quite important. Now, why are these 2 things important? Well, the first one, because it raises the probability that the current symptoms are due to a further herniation of a disc. The second one, because it's to do with severity. It tells you that there's a high likelihood of a Perdana syndrome and the complications of that, which are to be avoided. You now proceed to physical examination of this patient, so please write down now 2 abnormal signs, the presence of which would prompt you to arrange urgent investigation. Again, as in the first question, including more than 2 or not include those deemed to be the most relevant will afford you a 0 grading. So on examination, you should check for the absence of an ankle reflex on the affected side. You should also look for loss or reduction of perineal sensation. Now, why should you look for these? Well, loss of ankle reflex is quite a significant development, and even more so, loss or reduction of perineal sensation suggests that there probably is a cauda equina, and it means this is urgent. If you do discover these physical signs, then this is an indication for an emergency blue light ambulance admission to a neurosurgical center immediately. Please now list 2 investigations which you would prioritize in helping you to make a prompt correct diagnosis in this case. Again, if you include more than 2, or if you don't include those deemed most relevant, you'll receive 0 marks. The first is an MRI scan of the lumbosacral spine, and the second one is a chest radiograph. Now, the obvious question is, why these? With the MRI scan, you want to make sure you get an accurate diagnosis of this man's pain. He's in his 60s. This is not your typical acute muscular pain. And the probability of underlying serious disease is high. He's also still a smoker in his late 60s. Therefore, a chest x-ray would be important to rule out a primary lung cancer from which he has developed lumbar metastasis giving rise to this pain. Case 2. This is slightly different, is that you are working as a hospital doctor, in this case in HKL, and you're a locum as in an A&E department. An 86-year-old woman has been referred from a nursing home by a locum GP. The only history you know is that she's had 7 years of vascular dementia. She has hypertension and atrial fibrillation. She doesn't make any communication with the nurses. Her only treatment is donepezil for her dementia. She has one son who is currently traveling in India and is not contactable at the moment. The letter from the nursing home didn't have much significant history of the recent problems, apart from the past history referred to above. The locum GP who referred her in had never seen her before. In her current status, she is hitting out at nurses who are trying to examine her. With the information available here, please now list 2 diagnoses that would be important to confirm or exclude promptly in this acute situation. Again, if you list more than 2, you will receive 0 marks, and if answers you offer are deemed irrelevant based on the history shown, you will again receive 0 marks. Okay, the first thing to exclude is acute stroke, cerebrovascular accident, or otherwise known as CVA. The other one is acute myocardial infarction and or acute heart failure. Now, why these? Well, this is a lady who's got hypertension and atrial fibrillation, and she is uncommunicative and showing aggressive behavior. There's clearly been some acute event, and without her ability to give a history, you have to consider the possibility, because she has risk factors for it, of an acute stroke. Similarly, this sudden change behavior could be due to another vascular event, and the most important ones would be acute myocardial infarction and or acute heart failure. These could be related. Acute myocardial infarction in this age group with her background vascular history could predispose to simultaneous acute heart failure from left ventricular systolic dysfunction. The physical examination you conducted reveals the blood pressure was 190/80, her pulse is 120, and in atrial fibrillation. She had no fever. Her chest was clinically clear. Her abdomen appeared to be tense, but you couldn't be sure whether this was guarding or just a general state of anxiety, and she seemed stressed. The A&E doctor sent bloods to the laboratory for urgent analysis, including arterial blood gases. This doctor considered a urinary tract infection as a working diagnosis and started intramuscular antibiotics. Given the background history of the dementia, etc. for 7 years and being uncommunicative, he decided that a do not resuscitate order should be approved. Please now comment on what should be done next. Well, what was done next was this. She remained unwell and agitated. Some of her bloods came back and were reported as near normal, ESR, CRP. You began to wonder if this really was an underlying UTI, given that the CRP particularly was near normal. The registrar at A&E takes the initiative and rings the nursing home for further information, and this is what he is told. She recently had an episode of sudden acute and chronic confusion, given that she's a background of chronic confusion, associated with probable abdominal pain. This is all worked out by inference. She's unable to give a history, but they note that she was holding her abdomen, and subsequently she had 2 episodes of loose blood-stained stools. Now, in the interim, other blood results have come through. The full blood count was normal, so there's no anemia, and her arterial blood gases are also normal. Does this background information help you, and these normal results help you? What is now your likeliest diagnosis? Please now list 2 diagnoses that you would think are the priority diagnosis. If you suggest more than 2, or if your suggestions are deemed irrelevant, you'll receive 0 marks. The diagnosis suggested here would be acute mesenteric embolism and an acute exacerbation of uncontrolled atrial fibrillation. Why? There's a history that a few days before she was holding her abdomen and seemed to be distressed and more than usual. We know she has rapid AF, her heart rate was 120 and it's still in AF, that's uncontrolled. And therefore she's at risk of developing some embolic phenomenon, a stroke or some other. But given that she's holding her abdomen a few days ago and she had these blood-stained stools, this is a highly probable diagnosis. Now what you should do about that is contentious. The diagnosis of ischemic colitis and background atrial fibrillation was made, but she quickly deteriorated with a poor urinary output and poor cardiac output. You agreed with the first doctor's view that she should not be resuscitated, and the ladies later pronounced dead that morning in the A&E department. Subsequently, however, her son sends a letter to the hospital. He asks how his mother was allowed to die. He wondered if an earlier diagnosis of the mesenteric colitis would have an operation would have saved her. And he wondered who made the decision to not resuscitate her, and how this decision was reached without any reference to him. He feels that although he was traveling in India, he was potentially contactable and they should have made an effort to do this. What's the expert view in this case? Emergency surgery in this situation is contentious. There's no guarantee of survival. In fact, survival may be worsened, especially if performed as an emergency by inexperienced surgeons in training. However, on a separate issue, it's very difficult to defend the decision by a junior doctor with no reference to seniors who either do not resuscitate. There should be a hospital guideline on do not resuscitate orders with emphasis on shared decision making. There is no documented assessment of mental capacity in this case. And communication with next of kin is very important, especially with decisions about care at the end of life. Case 3. A 67-year-old with increasing severe back pain. The history of 1 month, it wakes her from her sleep, and she's had a poor response to regular paracetamol. There's been no trauma. There are no neurological symptoms, no fever, no night sweats, no weight loss. Her background is that she's a smoker, 30-pack years. She had a recent DVT a few months back, and she's recently noticed, and her daughter has noticed, a loss of height. These are her medications, warfarin and paracetamol only. She doesn't take anything over the counter, and she's no known allergies. When you examine her, you note a thoracic kyphosis. She is also tender in the lower thoracic spine. She has a limited active ROM of the thoracic spine because of pain. Her heart rate is 80, BP 145/90, temperature 36.8, respiratory rate 12, and her O2 sats on room air were 99%. Her chest was clear. First of all, what diagnosis would you now consider in your differential diagnosis? List 2 that you feel are the most important or urgent to confirm. Again, as in previous questions, more than 2 or diagnoses are considered inappropriate will receive 0 marks. Okay, these are the diagnoses considered the most urgent and appropriate. Osteoporotic vertebral collapse or malignancy with a metastatic lung deposit also leading to vertebral collapse. Why are these important? Well, she's 67, she's a smoker, she has shown loss of height, she's tender in her spine. So she's at risk of both osteoporosis and a lung malignancy with secondary deposits. With respect to establishing a diagnosis, what initial, easily arranged investigations would you prioritize from the list shown below? You may select up to 2. Now, in this scenario, you're a GP, you're not a consultant physician or an internist, so stick to the instructions. You will again lose marks for selecting more than two or two that are deemed inappropriate. The two that are deemed most appropriate are thoracic spinal X-ray and the chest X-ray. Why are these more appropriate? Well, first of all, many of the others on the list are inappropriate and very wide of the mark, and some are not easily obtained as a GP. So a thoracic spine X-ray will show you the vertebral collapse. If it's there, it'll show the osteoporosis. And the chest X-ray may show you the primary lung cancer. Question 3. A question on management for this lady. Her pain has been unresponsive to regular paracetamol 4 times daily, which is taken quite diligently, so she needs improved pain control. From the list shown here, which is the single most appropriate drug to prescribe today for her to manage this pain? And the list is morphine, diclofenac, fentanyl patch, celecoxib, tramadol, or ibuprofen. The answer here is tramadol. And why? Well, basically this is an exploration of the WHO pain ladder. She's already taking non-opioids and paracetamol and regularly. She's 67, so diclofenac and ibuprofen would not be appropriate, neither would celecoxib, not because of the GI upset, but that's a consideration also, but also because of the vascular disease that they can bring on. Cardiac events, fatal and non-fatal, are increased by the regular prescription of non-steroidals to those all aged over 65. Fentanyl patch is only used for those who are stable on a strong opioid. She is not yet, she's only on paracetamol. Morphine is probably too strong at this point for her, though you may gravitate towards that. Tramadol would be the next, let's say, middle-of-the-road opioid before you go into stronger opiates like morphine. Case 4. A 72-year-old man with fatigue and breathlessness. This man was brought to you by his wife with a 2-month history of progressive fatigue, lack of energy, and breathlessness. He's got hypertension and also had an infarct, a myocardial infarct, when he was age 64, 8 years ago. He said no angina. He said an occasional trouble with hiatus hernia, but generally this is resolved in the past with antacids. He's a non-smoker who drinks 2 whiskies each night, watching the TV before going to bed. He daily has a walk along the beach with his wife. His usual medications are atenolol, 100 milligrams daily, and bendraflumethiazide, 5 milligrams daily. He has no known allergies. His wife adds that he cannot keep up with her on their walks, and he started to get breathless even when taking a shower after a shower toweling. Based on what you've read so far, which 2 diagnoses are most likely to be responsible for his breathlessness and fatigue? The answers are chronic heart failure and anemia. If you list more than 2, you get 0 marks. If you don't list either of these 2, you also get 0 marks. Now, why are these more likely? Well, he's certainly at increased risk of heart failure because he's already got ischemic heart disease. Even though he has no angina, he's had a damaged heart from a previous myocardial infarction. He could also be anemic because he gets intermittent heartburn, and maybe he's taking something over the counter. Maybe he's got very slow progressive oozing from his esophagitis. When you see him with his wife, you explain that you'd like to arrange some investigations to find out why these symptoms of fatigue and breathlessness have developed recently. He agrees to have some simple tests done at your clinic, but he's not happy to be admitted to hospital. In your GP clinic, which 2 of the following investigations would therefore be the most appropriate initial tests to choose for this man? The choice is from echocardiography, plasma BNP or NT-proBNP, 12-lead resting ECG, an exercise ECG, and a full blood count. Please list 2. These are the ones that you should prioritize in helping you to make a prompt, correct diagnosis. Listing more than 2 or not listing the correct answers will receive 0 marks. The answers are a 12-lead resting ECG and a full blood count. Why? Well, if he has a totally normal 12-lead ECG, then the likelihood of chronic heart failure, which you would be considering in this case, would be very low. Given that he could have anemia, it's important to have a full blood count. Symptoms of heart failure are non-specific, can often be due to anemia, renal impairment, COPD, varicose veins, and a whole lot of other things. So these two investigations, so one is to exclude and the other one is to confirm or exclude. His ECG actually shows Q waves from his previous heart attack, but no other features. His full blood count is normal, with no evidence of anemia. You explain to him that a condition called heart failure is the most likely cause, and that it will need further investigations at the local hospital. But only at the outpatient clinic. He does not need to be admitted. He's happy to continue with this arrangement. You arrange an echocardiogram for him. This subsequently is reported as showing left ventricular systolic dysfunction, but is otherwise normal. His valves are normal, etc. His ejection fraction, however, is quoted as 37%. He comes back to see you for the results and your further management advice. Of the drug treatments listed on the next screen, which two would be the most appropriate initial management for this man? The choices are: change bendraflumethiazide to furosemide 40 mg twice daily, add ramipril 1.25 mg once daily, change atenolol 100 mg once daily to bisoprolol 2.5 mg once daily, or add verapamil 40 mg 3 times daily. The correct choices are to add ramipril 1.25 mg once daily, and change atenolol from 100 mg once daily to bisoprolol 2.5 mg once daily. And the obvious question is why. This man has got heart failure, confirmed by echocardiography, with a background of ischemic heart disease. He's in the older age groups. The evidence for ACE inhibitors and beta blockers is immense. So ramipril, first of all, should be started and then escalated gradually up to 10 mg daily as a target dose. Similarly, though he's on the beta blocker, there is no evidence that atenolol has any benefits in heart failure. It may have, but no studies have revealed this, but they have revealed overwhelming evidence for bisoprolol, carvedilol, and possibly nebivolol. Metoprolol is we're uncertain about its benefits. Bisoprolol is widely available as a once daily, and again the dose would be titrated up, if tolerated, to 10 mg once daily, but very gradually. In addition to taking the medications that you have prescribed for him, his wife inquires if there are any other strategies he could adopt or interventions he could have that could help him stay well. Of those listed below, choose two which could help to reduce the likelihood of worsening of his heart failure or to reduce the chance of being admitted to hospital due to heart failure. And the options are as follows: addition of daily vitamin C supplements to his diet, maintaining his regular daily exercise, reduction in current daily alcohol consumption, or ingestion of garlic capsules with food at least once daily. Now, listing two or more or not listing the correct answers will again receive 0 marks. The correct answers are reduction in current daily alcohol consumption and maintaining his regular exercise. Why? The evidence is overwhelming that patients with heart failure who also consume alcohol excessively, he's drinking 2 glasses in the evening. Now, 2 home glasses are almost certainly double the usual recommended daily measures. So that's probably 4 units rather than 2. So he's drinking, and this is a conservative estimate, probably 28 to 30 units daily. Given that he has heart failure, this is going to exacerbate his pump function and will make him worse. It may lead to, therefore, to increased likelihood of hospitalization due to heart failure or worsening progress of the heart failure. Similarly, he has regular daily exercise with his wife, and he should keep this up because regular daily exercise has been shown to reduce the likelihood of hospitalization due to heart failure or more rapid progress of heart failure. Case 5. A 68-year-old man attends your clinic. He has a 40-pack-year smoking history. His medical history includes COPD, hypertension, and hyperlipidemia. His medication include salbutamol inhaler, ramipril, and simvastatin. He has no known drug allergies. He's never been hospitalized for any of the above conditions. He reports recently a worsening shortness of breath with a wheeze of relatively sudden onset for the past week. He also feels more tired. He has intermittent chest pain and ankle swelling. On examination, his blood pressure is 135/84, his temperature is 37.5 Celsius, his saturations on room air are 93%, and his respiratory rate is 18 per minute. He has audible wheeze and pitting edema to the mid-tibial region. You suspect an exacerbation of his COPD. Of the investigations listed below, which two should be prioritized to exclude other causes? Please select a maximum of 2 from the following list: chest X-ray, electrocardiogram, spirometry, sputum culture, full blood count, peak expiratory flow rate, urea and electrolytes. Listing more than 2 or not listing those deemed to be correct will receive 0 marks. The correct answers are 12-lead ECG and a chest X-ray. Why? In this age group, with the background history he has and his smoking history, you have to exclude ischemic heart disease, an acute ischemic event, as the cause of his worsening breathlessness, even though he's got a background of COPD. A chest X-ray should also be done because you also have to exclude other causes, such as lung cancer. 1 year later, this patient returns for a repeat prescription of medications. He is asymptomatic and feels well. You arrange pulmonary function test. You subsequently receive the report from the respiratory lab, and this is shown here. It shows the following values. FEV1 is 2.26, pre-reversibility 76%, post-reversibility 76%. His FVC was 3.06, pre-reversibility 90%, post-reversibility also 90%. His ratio of FEV1 over FVC is 73. Pre-reversibility was 62 and post-reversibility 62 also. Which features did these pulmonary function test report results demonstrate? Name 2 only. Naming more than 2 or not naming the 2 that are correct will give you 0 marks. This report shows an obstructive pattern and it shows non-reversibility, and these 2 confirm COPD rather than asthma as the underlying diagnosis. Based on the GOLD staging system, what category do these pulmonary function tests indicate? Please name 1 only. This is stage 2 COPD according to the GOLD system, otherwise referred to as moderate COPD, or if you only state COPD, this is deemed incorrect, and if you state some other answer, that's also incorrect. He returns a number of times subsequently with a productive cough, wheeze, and shortness of breath. In between these episodes, he is well. What additional management would you consider? Select from the list below a maximum of 2. Influenza vaccination, inhaled corticosteroid, long-acting bronchodilator, long-term oxygen therapy, low-dose oral steroid, prophylactic antibiotics, respiratory specialist referral, slow-release theophylline, smoking cessation counseling. Again, if you select more than 2, or if you do not select the correct answers, you'll receive 0 marks. The most important and the most appropriate additional management strategies would be smoking cessation and influenza vaccination. And the reason is that patients with COPD who continue to smoke have a progressive course and have increased levels of exacerbations, leading to increased levels of hospitalization for COPD and increased levels of pneumonia and death. Influenza vaccination has been shown to reduce the likelihood of developing pneumonia related to Staphylococcus aureus in the aftermath of an influenza episode or an influenza-based pneumonia itself. These all lead to further exacerbations of COPD with the attendant complications of hospitalization and death. Thank you.